Caroline leads and executes the organization's strategy related to prevention, access to care, safety net programs, and health disparities. Caroline has a master's in government from the Johns Hopkins University and a BA in American Studies from Goucher College in Baltimore, Maryland. Thank you, Caroline, for joining us today.
Hi, good afternoon, everyone. I'm really excited to be here for the call on Congress and excited to be able to talk to all of you about this bill, H.R. 1017 S 479, which Margaret sort of touched on. So I'm Caroline Powers. I work for the American Cancer Society Cancer Action Network, which I'm just going to call ACS-CAN because it's a mouthful otherwise. And I don't know how to do my slide. Oh. This? Yep. Okay, sorry. Okay, so where do I point? It's not.
It's here. There you go.
Oh, there it is. Okay, so right, I'm sorry, I got a little distracted there. So ACS-CAN, we are the nationwide nonprofit, nonpartisan advocacy arm of the American Cancer Society. We're located in every state with both employees and volunteers. We work to try to influence policymakers to ensure that the needs of cancer patients are front and center as they put together policy. Here in Washington, I'm on the federal relations team. We have about 9 other folks that work with me on a variety of issues. Margaret sort of went through my portfolio. But we really work to influence the Hill, White House, federal agencies, and we work together with other coalitions in town to try to do that. And so I think there was a lot of discussion earlier about 80 by 18. I saw Emily Butler-Bell in the hallway when I got here. And so ACS-CAN is also with over 1,000 other organizations committed to trying to increase the screening rate for colorectal cancer to 80% by 2018. We know that this will save lives. Research has shown over 200,000 lives would be saved if we're able to reach that goal. As all of you know, 90% of those diagnosed with colorectal cancer at an early stage are still alive 5 years later, which is why screening is so important. But only 39% of all colorectal cancer screenings are actually diagnosed early. So we're sort of all hands on deck trying to get everybody screened. Which gets us to this bill. And why focus on Medicare is something, a question I get actually quite a lot. And number one, this problem in Medicare exists where it doesn't exist for those in private insurance, and that is when someone goes in for a screening colonoscopy that's supposed to be free. If a polyp is found and removed, they're charged. So that's why we're focused on Medicare, to fix this glitch. Medicare is a very large program. 55 million Americans are actually get their health coverage through the Medicare program, so it's a huge population. They are 65 and older, so they're at very high risk for developing colorectal cancer. And another reason is that 35% of those on Medicare are actually low income. So any barrier to care is, any financial barrier is going to actually impede their ability to get a screening colonoscopy. Right now, Medicare does cover, like I said, and I sort of repeat myself a lot, but I think, for me, I need to keep hearing something in order to get it in my brain. So in Medicare right now, screening colonoscopy is free. There's no deductible, there's no cost sharing whatsoever. But if a polyp is found during the screening colonoscopy, then somebody is on the hook for 20% coinsurance costs, which can be, on average, it's $300. So just to one more time, the glitch in Medicare, if a polyp is found during a screening colonoscopy for seniors on Medicare, then they are charged a surprise bill of 20% coinsurance, which doesn't make any sense for those who, you guys know intimately why the whole point of colonoscopy is to go in and find and remove polyps. So to have this sort of barrier, it doesn't make a lot of sense. It's completely illogical. And yes, right. So, and this is important for seniors. Again, cost is a barrier. Oftentimes, there's making decisions about what to pay for this month, and I have sort of a bit of an anecdote that really drove it home for me. I was talking to a GI doc who was telling me about her practice, and in her practice, they were, running into this issue where people were coming in for their screening colonoscopies, and polyps were being found and removed, and they're getting a bill for $300. And her office was getting angry phone calls from people saying, "What are you doing? I get this for free, and you're trying to charge me." And they'd explain, "Oh no, it's not us, it's Medicare." So they instituted a new policy in the office that when a patient came in before the colonoscopy, they would sit them down and say, "Okay, you're on Medicare. Let me explain exactly what happens here." And once they sort of explained to the person, it's free except if we find a polyp, then we're going to have to charge you out of pocket. And on your, this particular situation where we are, it's going to be $300. And she had two specific instances that really sort of spoke to why this is such a barrier to colonoscopy for folks. One gentleman told her, "Well, doc, if you see any polyps this time, just leave them. I'll come back another time when I have the $300. I just don't have it right now." And then another woman told her, "Well, I don't have the money right now, so why don't we reschedule this for some time later in the year, and I'll save up just in case." I mean, obviously, right? I mean, those sort of stories make me so angry and really sort of drive home why this is an important issue. So that's why we have the bill. HR 1017 in the House, Senate 479 in the Senate. And it's a really simple bill. It's exactly the same as as it was last year. It fixes this glitch in Medicare. It's bipartisan. Everyone sort of agrees on the policy that this is stupid and we need to fix it. Last Congress, because of you guys, we got an amazing amount of support, 289 House members, 40 in the Senate. The problem is that we're starting over. In January, we convened a new Congress, which means that in introducing these bills, they start with 0. So right now, as of today, I checked, there were 22 co-sponsors in the House, and we're up to 4 in the Senate. So there's a lot of work to do in order to get those co-sponsor numbers up. And our goal this year is to get to a point where we increase the numbers and we can apply pressure to the committees to have a hearing, which last year at the end of the year with Margaret, we started having conversations about hearings because of the support for the bill. But the other thing to remember about Congress is they move incredibly slowly. I mean, for those other issues like establishing the National Breast and Cervical Cancer Early Detection Program at CDC, it took over 10 years from sort of, let's do this, to getting it to a point where it was being signed by the president, and then another year to get it funded. So it's a slow process. I know it can be frustrating, and it's sort of like, I've already asked this member to co-sponsor this legislation. I did my job last year, but you have to do it again. So, and I think for those members, those of you who are lucky enough that your member last year actually co-sponsored the bill, go back in, say, you remember me, you remember my story. I am so thankful last time you helped us, you co-sponsored this legislation. I'm asking you to do that again this year. And hopefully that's an easy conversation. For those of you who have a new member or freshman member, fresh meat, as I like to think of them, this is your opportunity to go in and educate them. Tell them your story. Tell them why colorectal cancer screening is so important and why you want them to co-sponsor this bill. And so those are two instances where I think, we can get tomorrow, get those numbers up real quick so we can start putting the pressure on the committee to have a hearing. For those of you who come from states or South Carolina, where you have members who maybe haven't co-sponsored before, go back, say, you know what, you didn't co-sponsor this last year, I'm really disappointed, I want your help this year, and then say I have to wrap, I'm sorry. And ask them what kind of information would be helpful for them to sign on to the bill. And a lot of times what you're going to get is this knee-jerk reaction of, well, I don't know how much it would cost, what the impact would be on the federal budget. So this time I think what we want to do is say to them, you know what? I want to help you get as much information as possible on the bill. That's why I'm asking you to send a letter to the committee asking them to hold a hearing, because when they hold a hearing, we'll actually get a cost for the bill that is official from the CBO. And I think that is it for me. So sorry, I went a little long, but do we do questions now or? We're going to have Dr. Jones come up next. Okay. Oh, I go up here. Sure. I'm sorry, I went too fast at the end there. So if you have a member who says that they won't co-sponsor or they can't co-sponsor because they don't know how much the bill costs, what the impact would be for the federal budget, I would suggest that you say to them, I understand that. That's a legitimate concern, wanting to know the cost, because for some members, that's their sort of number one issue. What would the cost be? However, the way that you can help me to get that information for you is to send a letter to the committee asking them to hold a hearing, because one of the things, the usual process in Congress is before a bill is heard in committee, the Congressional Budget Office does a cost estimate of the bill so that members know as they go through the process what the potential impact would be. So we've really sort of struggled with some members who want the cost before they'll co-sponsor or support the bill. And the best way to get that is to have a hearing. So that's a suggestion. And I think they want Whitney to go. So there's and I'm sorry, I know you want to keep, is that, okay. So for Medicare, actually, pathology is covered, even for Medicare beneficiaries. And the issue that you're talking about in private insurance was actually addressed late last year through the Obama administration came out with new information for insurers saying that they needed to cover the entire colonoscopy, including if if polyps are found, pathology, anesthesia, and have no cost sharing for the patient. So that's actually been fixed for private insurance, but Medicare still has sort of this big issue with the polyp removal itself. So, and I went over. So, should I?
Thanks, Caroline. That's very helpful. And we'll have more time for questions later on these issues. So now I get the pleasure of introducing Dr. Whitney Jones, and he's the founder of the Colorectal Cancer Prevention Project. Dr. Jones is a practicing gastroenterologist and clinical professor at the University of Louisville. In 2003, he founded the Colon Cancer Prevention Project, a leading information advocacy organization. Through the leadership of the Colon Cancer Prevention Project and its many partners, Kentucky has made more than doubled its screening rates, cut colon cancer mortality by a third, and it passed into law the lowest barriers for CRC screening of any state in the country. So thank you, Dr. Jones, for joining us today.
First of all, I'd like to thank Rajid, my cab driver, who got me over here from Reagan in about 9 minutes, because I landed at 12:55. And thank you guys for having me. And you know, Colon Cancer Awareness Month, you know, I propose down the road we change it to Colon Cancer Action Month, because we're all aware, right? That's right. So I'm going to roll to a couple things. I get the great honor of talking about the CDC today. Here's my clicker. But I want to tell you a couple things. The Medicare glitch, you know, I love the term bait and switch, because I'm always looking for a loophole, but my patients aren't looking for loopholes. It's a big deal. We closed the loophole in Kentucky for non-Medicare patients, as many states have. So it's really important to get on these Congress guys for this, because nobody likes a bait and switch. Number two, just as a question, who's ready to disembargo information to the under 50 population about colon cancer risks, symptoms, awareness, prevention modalities? Anybody here? I missed the morning, but I heard about it. Great. That's going to be part of this discussion moving forward. Now, going into our CDC talk, I want to give you my CDC story. Who's from the South? Everybody here from the South? The whole room? All right, well, let me tell you our little story in Kentucky about the CDC. We started in 2003, and I started going to these meetings, and I'm like, well, CDC, that sounds great. What's the CDC? 5 years later, I set up in front of our state consortium, and I said, hey, guys, because we're number one in the nation for colon cancer incidence. We were number one in mortality. We're 49th for screening. You can't get much worse. I said, the CDC is not coming to Kentucky to help us. Do you know why? I know that. Because they would have been here by now. Okay, and so to make sure that the CDC is coming to your state in the future, we're going to ask for more money focused on colorectal cancer to your states in the South to be there to help screen people, educate people, improve your systems. So again, the CDC has a Screen for Life program. It's called Colorectal Cancer Control. And it's in about 20-something states, 22 states, 4 tribal areas. But unlike breast and cervical, which is in every single state, we don't have it. We don't have a Medicaid waiver that if you get caught with colon cancer or some kind of problem in one of these states that you roll onto the Medicaid program to get your surgery, your chemo, your treatment. We don't have any of that. I mean, what is it with the tatas that isn't helping with the babas? You know? I mean, really. As I say, everyone either has or at one time in their life has had a colon. All right, so let's get real about it. So again, that was the past. I think it's great. Kentucky has since gotten a CDC transformation grant. So your states need to get those too. Not just awareness, action. The program supported by the CDC has screened almost 55,000 patients across the nation, diagnosed 165 colorectal cancers and 8,500 polyps. That's a lot, but it's a drop in the bucket. Because if you look at these states that have received these monies, they have not been in the southeast of the United States. And we know we suffer disproportionate burdens of colon cancer in the southeast, and because of that, we need to get to the front of the line. If we're ever going to make 80 by 18, you got to bring everybody up, particularly the guys who are suffering the most from this. 2015, 31 grants for change. Ours works in health systems and community health centers. It's a 5-year granting program. I hear the enthusiasm from this group that 5 years seems like a lot of time. I mean, I suspect everybody wants to get started on this now, last year, 5 years ago. So what we are looking to do is to accelerate the CDC's involvement in states across the nation by asking for a $70 million appropriation for the CDC to expand this to every single state in the nation, including the southeast states. Anybody okay with that? You're going to have to get more okay with that to convince these guys up there. Right, and by the way, I do believe in advocacy. We've seen it work in Kentucky. I believe it does work at the national level, but it takes work and it's a slog. So be prepared to go up there and fight for this. Increased funding is going to help more states get information. It's going to help more states support screening for the uninsured. And it's going to take us further down the road where we all see a life where we've gotten rid of this nasty, pesky disease in our lifetimes, not in our lifetimes. So thank you very much.
Thank you so much, Caroline and Dr. Jones. So I just want to point out some resources really quick. If you haven't already noticed in your binder, there's a tab that says legislative goals. So they should fall into order with how we're covering them today. So if you want to follow along there, I'm sorry, I should have mentioned that at the beginning. But that is there for you to use. And then additionally, on the resource table, we do have some more information about the program that Dr. Jones just spoke about. We have information on whether your state was funded in both grant cycles. So in 2010 and or in 2015. So it may surprise you. Your state may have had one before and doesn't now, or didn't have one and does have one, or maybe was never funded at all. So I'd encourage you to pick up that information, take it with you to your meetings tomorrow, so you can point out, hey, our state has never had this program, or we used to have it and now we don't, or we have it and it's awesome and we want to keep having it. So overall, to summarize what these guys just talked about, and then we'll go into a Q&A, access to screening is essential for those of screening age. Medicare beneficiaries and those in underserved communities face barriers that we have to fix. We have to remove those barriers. So Congress can help remove barriers to screening by fixing this problem with Medicare legislation. So again, to recap what Caroline said, screening is free for Medicare patients. So they go in under the impression that they have no cost whatsoever, and they can potentially wake up with a $300 or more bill. I don't think anyone wants to have that happen, especially if you're on a fixed income. And given the average age of colorectal cancer diagnosis, I don't think it'd be too far-fetched to say that many Medicare beneficiaries have had friends who this has happened to. And if your friend said, hey, I went to the doctor, had this procedure done, it saved my life, but it cost me like $500, you might or may not want to go. So we just are working our hardest to get rid of that by passing the Removing Barriers to Colorectal Cancer Screening Act. And then additionally, the Colorectal Cancer Control Program at the CDC serves communities with underinsured and uninsured individuals. But it also raises awareness and has outreach programs as well as systems change to make sure that people understand, why am I getting a colonoscopy? And then if they don't have access to get there to the facility to have the colonoscopy, a lot of times they have programs in place to help with transportation, patient navigation, just making sure that there's follow through there. So it's a wonderful program, and we would love to have it in every single state. So we'll open it up now to Q&A. If you guys could use the floor mics this time. We have one on each side of the room, so if you have a question about these two issues, feel free to come up to the mic, and our two speakers will take your questions.
From Tennessee, we have like really conservative spenders. So just like she was mentioning, what do we say when they're worried about the cost analysis with the CDC? Do we say the same type of thing? Do we say, why don't you send a letter and hold a hearing, or to your committee to hold, like what do we say on the other ask?
I like saves lives, saves money.
It's just, it's hard to prove the cost analysis, even though it seems like so duh, you know?
I would say it's probably just about the same price to prevent it as it is to treat it, because otherwise the insurance companies wouldn't be for this. They'd be fighting it. They'd be against it. So I try to keep it simple with legislators, quite frankly. You know, it's a cost-neutral issue. Where do you want to spend your money, on the prevention side or on the treatment side?
Right.
When you spend on the treatment side, you're paying for unemployment insurance, you're paying for people to go on disability, you're losing productivity, you're losing revenue in your tax base, you're losing all the things that you want for the citizens of Tennessee, all the volunteers down there.
Right, and I really want to be writing down
with them,
this.
though, if you get into the weeds, though, it's going to be tough. I think the weeds are awfully tough with legislators. They're surfing up here, in my opinion. I mean, you guys, tell me your own opinion.
And the other thing to note about the CDC program is that it really, it's not a cost issue in the same way that the Medicare bill is, because it is part of the appropriations process, so it's a priority issue. Already there's a pot of money that is being sort of allocated for the CDC, and then legislators have to make the decision about how much goes to each program. So, I mean, what you're asking basically for them to do is to make colorectal cancer screening a priority issue for them, which is a little bit different.
Thank you for saying
But that's a great point, because remember, in Tennessee, it is the #2 cancer killer of folks from Tennessee in every state, behind lung cancer. And so, if, you know, it should get appropriate prioritization when you're looking at how to spend that money.
And how did you know the stats for Kentucky? Because I would love to go in with the stats of Tennessee.
Which stats for Kentucky?
We have on that. Oh, sorry. Can you hear me? In addition to the resource that has whether or not your state has a program or had a program, we have the American Cancer Society information for expected deaths and rates out there. So is that what you're asking about?
He knew that Kentucky was #1 in occurrences, #1 in mortality of the 50, and then 49 in screening. I wanted those particular stats, and all I found was a map, not like
Right. They're sort of, I know with the map you're talking about where you push on it, it's color-coded and everything like that, but there's a rank order within the ACS statistics. I mean, I'm going to throw it to my ACS partners. I know all that because that's all we talk about is where we were and everything. And we're sixth in mortality now, by the way, not number one, thank you. But how about this? Before we get done with this, we'll provide those resources and maybe we can put it up on the screen. And because it is important to know where you rank. Okay. Because who wants to be behind Kentucky, right? Sorry.
Now, are we asking for an additional $70 million or a total of 70? So what are they spending now on the 22 states? And then how much more, what's the difference in what we're asking for?
So in past years, we've asked for 70 million to fund every single state. And currently, we have 43 point something million. And that only funds about 25 states and some Indian tribes and certain
So we're asking for an additional $30 million, which is a small piece of change in the big scope of things. And
$1.2 trillion budget.
right. So and to the point with Tennessee before, I think what I would say to them is, how do you feel about 22 other states getting this benefit and your state is not getting this benefit? And that's what you should say to them. That's something that we should have. I'm from Tennessee or I'm from New Jersey, and we should have it. Why do they all get it?
And Emily did say that there is a sheet that lists those states that get that funding. So it's very important that you grab that in the back.
And I don't know if this is in the back, but how do we know, I'm from Ohio, so how do we know if our representative was one of the ones that sponsored the bill last year? Oh, great, okay, so that's that.
Sorry, and I have just one more thing on that note. Her question was, how do you know if your member co-sponsored the bill in the past Congress? Soapbox is going to come up here in just a minute. They're the ones who schedule your congressional meetings. On your schedule, when you get it, it will say on there if they co-sponsored it in the last Congress, as well as with the new bill, if they've co-sponsored it yet. So you'll have that information right in front of you.
Okay, perfect. And then the only other thing I wanted to comment or maybe clarify was about the private insurance. So, because in Ohio, we got a bill for my husband's and we got a bill for my 21-year-old son from the pathology report. I mean, from, that they did the pathology. So do all states, are all insurances covering that, or is it state specific right now?
For those who are 50 and above who have the USPSTF A or B rating, so for screening, so for those who are 50 or above right now, if there is a screening colonoscopy with polyp removal, anesthesia, pathology, even the bowel prep, none of those things are supposed to cost anything out of pocket.
Okay, we got billed.
Unless you are in a grandfathered plan under the ACA, which there are very few left in the country, but this change only happened late last year. So if the procedure happened last year,
It was in December.
Yeah, so this would, I think the pathology would be in sort of the upcoming, it was a last minute sort of change.
So we probably missed it by a couple weeks.
Whitney, I'm so glad to see you here. To answer the question from New Jersey, it doesn't feel good not to get it, but I want people to be aware that the difference between the breast and cervical cancer program, that's a 50-state mandate. It was congressionally mandated. So over the past several decades, you may have heard a lot of pushback about justify any tax dollars, right? So justify. So the difference with the colorectal cancer programs is that the CDC did this with pilot studies, and they figured out what was going to be the most successful applicant, and those are applicants that have pre-existing programs. So the Kentuckys, the South Carolinas, the Arkansas, all of these states that were newly funded had state support. Coming from Mississippi, and I know there are 10 other states that applied. We submitted applications. We were told it's a very good application. However, we don't have money to fund you. So when you're hearing the pushback is going to be on cost effectiveness, and we have to push back with all of the states know how to do this. They don't have to use the State Department of Health. They can go through medical centers like they did in South Carolina and in Louisiana, et cetera. So push back hard on that. Thank you so much, Whitney, for leading this.
Round of applause for our panelists.
Our next speaker is someone we all know and love, and it's her birthday today, so say happy birthday to her. Nancy Roach. And many of you know that she's a strong advocate, yes, but did you know that she's a cancer survivor too? Not a colorectal cancer survivor, I'm sorry. Nancy knows how to make a difference. Nancy has been involved in the colorectal cancer community since 1996, when her mother-in-law was diagnosed with rectal cancer, and is a co-founder of the colon cancer and was a co